All right, welcome to Module 9, our lecture on bipolar. So these are the outcomes that are just listed in Blackboard, so you can read those when you have a chance. So there's two types of bipolar, bipolar 1 and bipolar 2. So bipolar 1 is the most, probably the one that you're most familiar with, if you're familiar at all. It's the most severe form. Of the types of bipolar, including the cyclothymic disorder, which we're not going to really talk very much about. It is the most deadly, just because of the extreme nature of the disease process, and by definition, it has at least one manic episode. And it's this alteration, or this alternating between mania and major depression. Mania is elevated mood, abnormally elevated mood. So much so that the person has to be hospitalized because they have lots of issues, including not being able to care for themselves, making really rash choices, those things like that. But we'll talk about that as we go through. And this mania episode lasts at least a week. Bipolar 2 is not as extreme. So you still have the swing between the two extremes, but the manic episode is hypomanic. So it's still mania. So don't think that it's like the opposite of mania. It's just like a pulled back version of mania. So they still have some of the similarities, just not the extremes. And it usually doesn't require hospitalization. Okay. And it lasts a shorter amount of time. So 4 days, and they usually have at least 3 of the mania symptoms, but they're not as impaired. These patients can progress to mania, and if they do, then it would be into bipolar 1. Okay. Yeah. So this is our case study. We're going to follow Miss A through this lecture. She's a 53-year-old admitted to the unit with bipolar disorder 1 and is in the manic state. What symptoms might you expect to see? So catatonia is like not responsive at all, right? So probably not, not associated with being manic, right? Expression of racing thoughts, that sounds more like it, right? Low self-esteem and tearfulness, what would that be associated with? More depression, right? And then lack of interest in her environment, again, that would be more depression. So some of the symptoms of mania include extreme drive and energy, like unbounded energy. They have this inflated sense of self-importance, like they're the most important person in the room or in the world. Drastically reduced sleep requirements. They don't have time for sleep. They don't need sleep. They're above the necessity of sleep. Excessive talking, pressured speech where they can't get the words out fast enough. Either they personally feel like their thoughts are racing. They can be distracted super easy by environmental stimulus. They're usually obsessed or hyper-focused on goals. Purposeless, like arousal and movement. So they just like randomly are moving without any intention. They engage in dangerous activities such as indiscriminate spending, reckless sexual encounters, or risky investments. Okay, so up to 21% of patients with major depression might actually have undiagnosed bipolar disorder. Bipolar 1 is more common in males, and bipolar 2 is more common in females. So Miss A reveals that she's an adjunct college English professor who has published 2 novels and is working on a third. It was almost inevitable, she says, because I grew up in a family of 5 anxious girls with competitive, ego-driven professional parents. It was hellish. I found escape in writing stories and putting on plays with my sisters. When I got a scholarship letter, I practically ran away to college, where I absolutely lived on coffee, books, and the drama department. Miss A further describes her childhood as part of her life, a part of her life she finds particularly troubling. We all had to compete if we wanted attention. Dad played favorites, depending on our grades and talents. I was his favorite, but I hated it because it made my mother hate me. How could she compete with her own daughters? Sometimes in high school, I scared myself with how much I just wanted to hurt them. Ooh, I decided I would never marry and have kids. So Miss A is all over the place, right? Risk factors. So if you have a parent with bipolar, um, you have a 15 to 30% greater risk of developing bipolar yourself. Identical twins, 70%. Both have bipolar. A number of genes contribute to this expression. People with bipolar do tend to have higher IQs. They're higher in it's higher in creative types, people that are highly educated, professionals. Um, there could be some issues with neurotransmitters or maybe the receptor sites if they're not sensitive or not, or dysfunction of the cortical region of the brain or the hippocampus or the amygdala, maybe some gray matter loss. They don't really know. It's kind of like a combination of stuff. Possibly thyroid issues, maybe stress or adverse life events. There's not a lot of evidence that there's any psychological basis, but substance abuse can contribute to it, especially alcohol and cocaine. Turns out they're bad for you. Okay, so some triggers. Substance abuse, like we talked about, alcohol, cocaine, even caffeine. Sleep disturbances, either before the onset, associated with the process itself, or when they have manic episodes. And then psychological stressors. Okay, based on her history, which factors can you identify that may have an influence on Miss A's condition? So it sounds like maybe her parents might have had um, potentially had bipolar themselves. So that puts her at risk. She's also got some psychological and environmental factors just from the dysfunction in her household. So all of the above, right? And this is a picture of bipolar. So the mood in mania is expansive, elevated, unrestrained, over the top, right? Um, in behavior, it's just excitable, uh, can't be still, almost out of control. Thought processes and speech patterns are just pressured, can't get the words out fast enough. Their brain or their mouth can't keep up with their brain. Um, they're very distractible, they're hyperactive, they don't need to sleep. They can dress really funny. They could have weird speech patterns, which we'll talk about. And then on the swing side of it, you have depression, right? So instead of thinking they're the most important person in the room, they think they're worthless, hopeless, those sorts of things. Very angry, irritable. Nothing interests them. They can't find pleasure in things that they usually would. They're very fatigued. They don't have any energy. They don't want to do anything. They don't want to eat, which is actually a commonality between the two. They struggle with insomnia as well, suicidal ideation. So one extreme to the other. Okay, so speech patterns. Pressured is like it's fast, it's inappropriate in how urgent they are. It's loud and rapid and incoherent. Circumstantial speech is adding unnecessary details. So things that don't even relate to the story. Tangential, tangential. It's like circumstantial, but they lose the point they were trying to make because they go off on a tangent. Loose associations is distorted information processing. So the thoughts are loosely connected. Flight of ideas, very fast speech, abrupt changes in topics. You can't even keep up with where they're going. Clang associations is stringing together rhyming words. And then for thought content, It's important that you understand what a delusion is. So, a delusion is a distorted or false thought. So, delusions happen in your head. Okay. Grandiose would be their achievements are exaggerated. Um, or it's super important to them. They think they have superpowers. They think they were abducted by aliens. They think they're the Messiah. And then persecutory is they think the FBI is spying on them. They're watching me. We're not safe here, that kind of stuff. So, what are some problems that can be avoided if your manic patient gets proper treatment? So remember, they have risk-taking behaviors, so it's possible that they could be harmful to themselves or others. They are at risk for suicidal attempts. Um, they do tend to be prone to alcohol or substance abuse, that making poor choices. Um, Potential for marital or work problems. If you can imagine, if you've got somebody with mania or depression, how that would affect family and work life. And then development of comorbidities. So if they're not eating correctly, if they're not sleeping correctly, if they're making poor choices, that could lead to other health problems. Okay, so it's really important as healthcare providers that we take care of ourselves while we are trying to take care of folks with mania, particularly. They can be really demanding, manipulative. They try to pit, one care provider versus the other, like mom versus dad kind of stuff. Well, they let me do that, trying to get whatever they want. Um, so for staff members, it's really important that everybody is consistent, right? You set the same limits. Everybody proceeds with the same types of rules. There's no bending. Um, Everybody does it the same way. So everybody sticks to the script. And having meetings where you discuss what these boundaries are going to look like, how we're going to deal with it, um, and those sorts of things. Whatever we need to tweak to make sure that everybody's on the same page. Okay, assessment guidelines. So remember, they are potentially a danger to themselves or others. Um, so just assessing for that. They need to be protected from their own behaviors because they're not necessarily keeping their own safety in mind. They can reach a point where they do need hospitalization. So assessing the safety aspect. So the safety is the important piece. Are they functioning in a way that they are not maintaining care for themselves, such that we need to put them in a protective environment until we can get them back under control? And then, do they have any underlying medical or substance abuse issues that are contributing to this? And then making sure that family understands the disorder, what medications they should be on, any support groups that might be available or organizations that can help them. Because I can imagine just trying to be a family member of somebody who swings through these extremes, and just the associated symptoms would be really challenging. Okay, so possible nursing diagnoses. So we talked about safety, right? So we can throw in, oh, it's not working. Sorry. Let's try again. I'll just tell you. So risk for injury, risk for violence, either directed towards themselves or self-directed, and ineffective coping would all be problematic. I tried to be cute and do a little animation and it's not working, so. All right. Outcomes. So, in the acute phase, we want to make sure that they don't injure themselves, okay? Um, the way that they can injure themselves is they don't drink enough water, they don't eat, make sure that they have stable cardiac function, that they're, not uh, intaking too much caffeine, that they're getting rest, that they're controlling their actions, that they're not going to try to harm themselves. When we get into the continuation phase, we want to keep them well because preventing relapse is really important, right? And then the maintenance phase, just limiting severity and duration of the future episodes. So whatever we can do to keep them healthy for as long as possible. All right. So planning, medical stabilization, making sure they're medically stable is really important, making sure that their environment is safe. And then for nursing care, we're going to manage their meds. What meds do they need to be on? Making sure that they take them at the appropriate times. Decreasing physical activity, so making sure they have opportunities for rest. Making sure that they are eating and drinking. Making sure they're getting enough sleep every night. And then intervening so that they take care of themselves. Sometimes that does involve a decrease of stimulus, such as like seclusion or restraint. And then ECT is actually considered during the acute phase, and it really does show some benefits. Okay, so implementation in the depressive episodes, it's the same as major depression, sometimes even more intense. If they are suicidal or psychotic or catatonic, we would hospitalize them. Um, we do have to be careful when we're medicating depression that we don't bring about manic episodes. Okay. Um, so when we bring them into the hospital, we're providing external controls to make sure that they don't continue in destructive behaviors, and then we give them meds to make sure that they're stable. Okay. And then manic episodes, if they're acute mania for bipolar 1, we would hospitalize them for safety, and then making sure that we're communicating around how we're going to manage that. And whenever you're communicating with them, and you're trying to maintain safety of a patient during the hospitalization, it's that limit setting that we talked about that has to be really firm while being non-threatening and neutral, so that you're not escalating the patient even more, and making sure that you're creating safe boundaries for the patient themselves and anybody else that they're going to be interacting with. All right, communication. We need to make sure that our communication again is firm, but calm. You want to keep it to the point. You don't need to go on, long explanations because they're not going to be able to pay attention. We want to have a consistent message, make sure that expectations are clear and consequences are clear as well. And then if there are any legitimate complaints, that you do take them seriously. And if they are getting distracted or whatever, or they are, just trying to contain that energy, finding constructive ways to do it in a way that they're not going to do self-harm. Okay, milieu. Milieu is a fancy word for environment. Okay, so it makes sense if you have a patient who is manic that you would want a calm environment, right? So if you've ever been to like Taco Cabana, it's bright pink, it's got loud music, it's got colorful flags. There's a lot going on. Versus like a spa or the waiting room of a counseling office, right? Those places are nice and calm. So we're going for calm. Low stimulus, solitary activities, they might get ramped up if they're with other people. We're not going to do charades or anything like that, right? Puzzles, reading books, frequent high calorie foods, lots of opportunities for rest, redirecting any aggressive behavior, making sure that we utilize medications, seclusions, restraints, whatever we need to do to make sure that they don't physically harm themselves or anyone else. If they are on lithium, remember lithium has a toxic level that you can get to, so making sure that we're monitoring for that, and making sure that we store store valuables, um, credit cards, cell phones, etc., until they have proper judgment. Can you imagine somebody with mania on Amazon? Oh my goodness, buy all the things. Okay, So again, psychological safety, if you haven't gotten that yet, safety is a big concern. So things like eyes and nose, vital signs, high calorie food, drink, reminding the patient to eat. They get so busy they don't remember. Sleep, making sure they get rest. You have an opportunity for low stimulus, ways to calm them down before they go to bed. And then making sure that they take time to go to the bathroom. They can get severely constipated because they just don't take the time to sit and go to the bathroom. So offering things like laxatives, high fiber foods, things that are easy to eat on the move. We're not going to go deep into the pharmacological stuff. Two main focuses are agitation and mood stabilization. Okay. Um, they need to be reminded that they need to take their meds even when they're feeling well. And that's a real challenge because they don't think they need to take them because they feel better. Remember, lithium has toxic capabilities, so patient and family should have proper instructions about possible adverse effects, signs and symptoms of toxicity, when they should call their doctor, the fact that they need to get periodic blood tests to manage their levels. And then there's two long-term risks of lithium therapy, including hypothyroidism and then some kidney damage. So make sure you're familiar with just these types of drugs. I think you cover them in pharm, so we won't do much with them here. Patient and family teaching. It's box 13.2 in your book. Know it. We're not going to go through all of it because you can do that on your own. All right. When we meet on Thursday, we will discuss Harding case 145. So be ready to talk about that. And I will see you then.